Hey guys, and welcome to another episode of Seize the Moment podcast. Today I have a very special guest on. Her name is Dr. Rachel Zoffness. Dr. Rachel Zoffness is a leading global pain expert, pain psychologist, and an assistant clinical professor at the UCSF School of Medicine, where she teaches a pain education course for medical residents. She serves as pain education faculty at Dartmouth and completed a visiting professorship at Stanford University. Dr. Zoffness is the author of the Pain Management Workbook, a highly accessible, easy-to-use guide for healthcare providers and adults living with chronic pain. Welcome, Rachel, and thank you so much for coming on the podcast.
You know, it's funny, no matter how many times people read my bio, I never get used to it. You know, I always like sit here feeling like embarrassed for some reason.
Well, I mean, yeah, it's super impressive, man. Like, you've done a lot of stuff in your lifetime. And it's like, yeah, you kind of read it and you're like, holy shit, how old are you again?
Yeah. It's funny. I hear it and I just sort of feel like I want to hide under a rock, but thank you.
You're very welcome. All right, so I'm gonna read a quote from something you wrote in the Psych Today article, and then we're gonna just get going. Okay, so Rachel wrote, "Pain is never purely biological, due exclusively to issues like tissue damage and anatomical dysfunction. It is also emotional, social, and cognitive, constantly influenced by thoughts, perceptions, emotions, and context." Okay, so where did the medical community essentially get this wrong, right? Because, you know, when I was a kid, and I guess even to some extent now, whenever I go to the doctor, like I have stomach pains, let's say, you know, a headache or whatever, you know, they'll constantly and consistently diagnose something physical, or at least inquire into, you know, the physical components of it. So like there was a moment where I remember I had to go see an allergist because I felt like my allergies were acting up and I was having like vertigo. And I came to him and I said, hey, you know, like my head has been spinning for a while. And he said, you know, it could be a brain tumor. Let's get you an MRI, right? Yeah. The first thing he says, let's get you an MRI. And I'm like, okay, can we like relax a minute? And can you like at least do a thorough assessment and let's figure out what the likelihood of that is before sending me to an MRI? So how does this happen? Why do medical professionals solely focus on the biology as opposed to the other aspects?
I have so many responses to the story you just told me. Like, thing number one, psychologists and people who work in healthcare have all heard of placebo, right? Like we've all heard of the placebo effect, right? Placebo effect is like words that someone uses or like a pill that you take that makes you feel better, even though it supposedly doesn't have any sort of like medical or like biomedical component. There's also something called a nocebo. A nocebo is the opposite. A nocebo is like, you know, a totally neutral pill or words that you use that can make someone feel worse. So when someone has a headache and you go see a doctor and they're like, yeah, it's probably a tumor. Like actually what science tells us is that words like that are going to make pain feel worse. So to answer the question you actually asked me, 96% of medical schools in the United States and Canada have zero dedicated compulsory pain education. Like zero. So where did we get it wrong? If you're asking me, it's our educational system. Like we do not prioritize educating healthcare providers in pain, not in medicine, not in psychology. Like we don't teach pain at all in most psychological programs because in Western medicine, we have this concept like either your pain is physical and you see a physician or your pain is emotional and you see a psychologist. But that's not how pain works at all. Like pain neuroscience tells us that emotions influence pain and thoughts affect pain 100% of the time. So where we get it wrong, I think, is like starting at the most basic is like the educational process. So if physicians aren't being trained in pain, how in the hell are patients like you and me supposed to understand pain, right?
Right. And you know, what's interesting is like thinking about it. And I even can imagine going to a psychologist and thinking, you know, like, hey, or telling the person, hey, you know, I've been struggling like with these stomach aches, again, maybe, you know, headaches or whatever. And that person sending me in turn back to that doctor and saying like, well, I'm not a doctor, right? What can I tell you? Like, this is physical. Like if you know, I can help you with potential, you know, with stress, depression, anger problems, whatever it is, but I'm not really sure what to do here. So like, how does that happen, right? Because you can end up in this feedback loop where the doctor sends you to a therapist and then the therapist says, well, I don't know, you should go back to the doctor.
You're like literally telling the story of my life.
Mm-hmm.
So I was a kid with chronic stomach aches, just full transparency. And it was anxiety. Like I was a socially anxious kid. I was a library mouse. I spent all of my time reading books. Books were my friends. I was like shy and introverted and scared of everybody. And I had chronic stomach aches. And at no point, literally until my 20s, at no point did anyone say, hey, did you know that stress and anxiety are somatic By that, I mean, they live in the body. Like emotions don't just live in your head, they live in your body also, right? And so, we've all heard of serotonin, which is that chemical that regulates mood. I think I was like probably 30 when I learned that 90% of the body's serotonin, do you want to know where it lives? 90% of the body's serotonin, you know where it is?
Can I guess in the gut?
It's not in your brain. That's right. Mm-hmm. It's in your gut. 90%. Like,
so
we take SSRIs like candy, like, antidepressants, anti-anxiety meds. It's like when you have a gut instinct, it's because 90% of your serotonin, like your emotion center, in addition to your brain, is also your gut. So like for some reason, medicine gets it wrong. Like I see all of these kids in particular, that breaks my heart, who have been down the rabbit hole with procedures and scopes. They've been anesthetized and like, it's great that we're ruling out the scary stuff. It's great that we should always rule out brain tumors. We should always rule out Crohn's disease. I'm not saying we shouldn't also rule stuff out, but I remember when I was an undergrad, I had an advisor who said, he didn't make this up. It's like something like, when you hear hoofbeats, think horses and not zebras, right? And like, I used to not know what that meant. What it means is when you see a symptom or you hear hoofbeats, you want to think of the thing that's more common. Like if you're here in America, chances are high if you hear hoofbeats, it's a horse, it's not a zebra. Chances are high when you get a patient who has a stomach ache or a headache, like the chances of it being a brain tumor are pretty low. The chances of it being secondary to stress and anxiety, given the culture that we live in, like during a pandemic, during this like epidemic of racism and like all the things that are happening, climate change and wildfires and flooding, like chances are high it's probably stress or anxiety. But for some reason in healthcare, we don't talk to our patients about this brain-body connection, even though it's clearly a thing. Like there's no way around it. If serotonin, 90% of your serotonin is in your gut, and we're treating stress and anxiety and depression with serotonin medications, let's talk about the role of stomach aches in stress and anxiety and depression, and headaches and the other things that happen to your body too. But we separate it out in Western medicine in this way that like boggles my mind.
Yeah. So can you take us through your journey? How'd you end up figuring this out? Like when did you finally have that aha moment where you're like, okay, yeah, maybe my stomach pains aren't purely physical?
You mean like, how did I get to where I am professionally or personally with the stomach stuff?
Technically both, right? Because I'm assuming the personal is connected to the professional, because I'm assuming in some way you were on your own healing journey before you decided, oh, I'm going to do this for a living.
There are two separate stories and I'm happy to tell both. The stomach stuff, I just went down the rabbit hole because I'm a nerd and I love biology. Like my major in college was brain and behavior, human biology, and I just wanted to know everything. So I uncovered this serotonin. It's called the enteric nervous system. The enteric nervous system is this brain-gut connection. And I discovered it on my own just by doing research. At no point did any GI doctor or any primary care physician ever tell me about the enteric nervous system. So that was just like nerdy reading. And now I'm obsessed with it. And I go around talking about it all the time because stomach aches are so ubiquitous. But the professional thing, like I always wanted to live at the intersection of medicine and psychology and neuroscience and education and science writing and like essentially helping people. And I wanted to do it in all these different ways. And I couldn't figure out how to like make all those things live together. So undergrad, I studied biology and neuroscience and psychology. And luckily there was a major at Brown that allowed me to do that. It's called brain and behavior, human biology. It's great. Mm-hmm. And then I like couldn't figure out what I wanted to do. So I taught science at the Bronx Zoo with these like nerdy 8 to 12-year-olds. It was the greatest job I ever had. I wrote for articles for a science magazine. It was like Natural History magazine in New York City. It was so cool. Mm-hmm. But nothing really hit it, you know? So I started doing research at the NYU Child Study Center and I got a master's degree in clinical psychology, but I still wasn't really, you know, and I had studied pain actually as an undergrad. That was my honors thesis. I was so fascinated by pain because it seemed to be this thing that lived at the intersection of biology and medicine and neuroscience and psychology, you know, and I was so fascinated by it. So I did circle back around to it finally after I got my PhD in clinical psychology, where I got zero training in pain. Uh-huh. And during my postdoc, I just really went down this rabbit hole. Like I did this training in mindfulness-based stress reduction, MBSR, which is a non-pharmacological evidence-based treatment for chronic pain. And I was like, how does this work? Like, it's helping all these people living with pain. How is that even possible? So I studied the neuroscience of it, and then I just like, dedicated my whole life to it. And I started going around like to pain conferences and taking all these pain workshops. And I emailed the people who were doing the research on cognitive behavioral therapy for pain. And I was like, I asked them, like, are you using a manual? Like, what treatment guide? And a couple of people, they just sent me the manual they were using in their studies, because studies are for public consumption, and most of these researchers want people like you and me to be delivering this to people in the universe, especially if it's effective. So I started using the manuals with some of my patients, and then I was so fascinated by it that I started giving talks at UCSF on how CBT works for chronic pain, and they were so delighted to have someone to send their patients to, especially the ones that weren't responding to medications, that they just started sending me all of their patients with chronic pain. And listen, like, I am not a miracle worker. Like, I'm just doing what I've been taught, but like the patients I was seeing were getting better. And I was seeing these like intractable pain patients who had been on 40 medications and had been in bed for 4 years, and they were getting out of bed and going back to life. And their physicians at UCSF were calling me, and they were like, what magic purple pill are you giving them? And like, and my whole thing was like, yeah, that's the whole point. I'm not giving them any pills. Like, actually, I'm doing this cognitive behavioral therapy thing, and they're getting their lives back, and they're going back to, going back to school and going back to work and going back to their hobbies. And yeah, it's pretty amazing. And then I became an addict. Like, when my patients started getting better, especially the teenagers, because I happen to have a soft spot for teenagers, like watching those kids get out of bed and back to life is magic. And I just never wanted to do anything else.
Yeah, I love that. So how should we understand pain, right? Because the way, let's say that I would think about it is, you feel pain, right? There's some tissue damage. All of a sudden there's a nerve signal being sent up to your brain. Your brain interprets that as pain, right? And then essentially you're like, oh, ow, right? It hurts. So where are we what are we missing here, right? Because it seems really simple and straightforward, yet you're saying it's more complicated than that.
Pain is super complicated. So I'll give you the nerdy neuroscience and you can decide for yourself. Ready? So
Yep.
It's really easy to believe that pain lives exclusively in the body. Like, if your back hurts, it's easy to believe that the pain lives exclusively in the back. But we know from neuroscience research that that's not actually true. And one of the reasons we know this is because of this syndrome called phantom limb pain. And phantom limb pain is when you lose a limb, like an arm or a leg, and you continue to have terrible pain in the missing body part. So if you can have pain in an arm that isn't there, that tells us definitively that pain is not constructed by the body, right? Of course, there's this brain-body connection, and the body's always talking to the brain and vice versa. But if you can have terrible arm pain in an arm that's not there, your pain must be constructed somewhere else. And that somewhere else, science tells us, is the brain. So there's lots of parts of the brain that produce the experience we call pain. There's like a dozen parts of the brain that are involved in this process, but there's 3 in particular that I find most useful when I'm teaching this concept of how pain works. So your prefrontal cortex is implicated in pain processing. So that's the part of your brain responsible for attentional processes and executive functioning. And your cerebral cortex, the part of your brain responsible for thoughts, and your limbic system, which is your brain's emotion center, also is implicated in pain processing 100% of the time. So literally what that means is pain is always 100% of the time, both physical and emotional. 100% of the sensory signals from your body filter through your brain's limbic system before they become the thing you call pain. So when we talk about pain as this purely physical problem, and we go after it using pills and procedures that are just targeting your leg or your back, ultimately it's not going to work. I mean, for an acute pain process, so acute pain is pain that's 3 months or less. So that's like a broken ankle or like the pain of childbirth, something short term. Yes, we can target that with like laying in bed for, however many weeks with a cast on your leg. But for something like chronic pain, we have to also target the brain in addition to the body, because otherwise pain is never going to heal.
So what's the connection then when it travels up the limbic system? What sort of emotions then are connected to pain?
The answer is all of them.
Mhm.
all of them. So what research shows is that positive emotions, so like when you're feeling happy and joyful, um, and things like safety. So when you feel safe and your body is calm and your thoughts are relaxed,
Mhm.
your brain will turn down pain volume. So pain will feel less bad when emotions are positive, like you're happy or joyful, or when you're feeling safe and calm and relaxed. And the opposite is also true. Neuroscience tells us that when you're feeling stressed and tense, or you think you're in danger, and your fight or flight system is activated, pain will be amplified. And when emotions are negative, if you're like depressed and miserable or angry and frustrated, your brain will also amplify pain, because at the end of the day, negative emotions you often experience when you're in a state of distress and you're not safe.
Right.
So if pain is your body's warning system, and that's really all it is, your brain is going to incorporate all of the emotional information too, because if you're feeling not safe, your brain is going to amplify the danger messages, and that's going to amplify pain. Does that make sense the way I said that?
Yeah, it seems so counterintuitive, because if you think about it, right, again, going back to that kind of first model, that medical model, where the idea is like there's tissue damage and your body's warning you about something, let's say horrific about to happen, right? Let's say maybe you're going to bleed out or whatever it is. And then, obviously just having a kind of open wound itself, it could get infected, right? So I guess I'm wondering, how does that work, right? Why is the emotional system even technically attached to this? Because if pain is just a signal, right, how is it possible that either the brain can detect pain when there isn't any pain, or it cannot detect pain when can detect damage rather when there isn't any damage, right? And can't detect damage when there is damage.
Will you say that again, but differently?
Yeah, so how is it that it's in some cases that essentially the brain is able to detect, or I'm sorry, is not able to detect damage, right? Tissue damage when there is damage. And then when it does, in some sense, right, detect tissue damage when there isn't damage, meaning that it sort of feels pain and tells itself the story like, oh, I'm in pain, here's why, right? And, I'm maybe upset about it or angry, scared, whatever, right? I guess it seems so counterintuitive, because you would think it's just kind of this A to B connection where I'm in pain or in danger, right? And then my body and brain detect it, and therefore I do something about
Okay. So to answer your question, there's a couple ways I could answer it. So I'm going to zoom out and just say, I'm going to use a big word. Ready?
it. Mm-hmm.
There's this fallacy that pain is this purely biomedical process. And by that, I mean, again, it's like just to do with damage to the body. But what we know is that pain is not a biomedical process. It's actually this thing that we call biopsychosocial.
Mm-hmm.
And literally what that means is, yes, there's biological components to pain, like tissue damage and system dysfunction, but that's only 1/3 of the pain problem, like the biomedical. There's also the psychological domain of pain, and there's the social or the sociological domain of pain. So the way I visualize it is like these 3 overlapping bubbles in this Venn diagram, and pain lives in the middle of those 3 things. And so you sort of need all of those things to produce this thing that we call pain, because the bio alone is not sufficient. So, and I'll tell you why, but in the psychological domain of pain, you have things like thoughts and beliefs. And what neuroscience shows us is that your thoughts affect your body 100% of the time. And if you've ever had stress or anxiety, you know that the things you think affect the way your body feels. If you start thinking panicky thoughts, you're going to have sweaty palms and a racing heartbeat, and maybe a stomach ache and maybe a headache, but your body is going to respond to the things in your head. So your thoughts are always affecting the pain you feel. And also in the psychological bubble are emotions, which we just talked about, and coping behaviors too. So how you're dealing with your pain affects the pain you feel. So people who are in bed for months and years feel worse and have more pain than people who are engaged in activities and seeing friends and doing things and are engaged in their lives. So the psychological bubble contains a lot of stuff. And the social or the sociological bubble is like everything else. So race and ethnicity and socioeconomic status and your social support network, whether you have friends and family or you're isolated. It includes like context and environment, so the things that are going on around you. So the thing that's important to know is that your brain is constantly taking into account all of those things all of the time. Because if you think about it, danger detection isn't just a sensation. It isn't just like a nail in your foot. It's also like what's happening around you. So here's a good story. If you're walking down the street and you feel a scratch on your ankle,
Mhm.
and you think to yourself, so say you're walking down the street with your family and like there's recently been a storm and there's like branches everywhere. And you think to yourself like, oh, that's just a branch from it's just a scratch. Your pain will not be bad. The context of that is your brain is like, oh, that's no big deal. If you're walking along in Australia in the outback and you feel that exact same sensation on your ankle and you think to yourself, especially if you've been told at the beginning of the hike that there's like deadly brown death adder snakes, in the immediate environment, and you think to yourself, oh shit, I've just been bitten by a snake, your brain is going to produce an insane amount of pain to protect you because your thoughts and your emotions and the context and the environment are always part of this pain process. Like your brain uses all available information to decide whether or not to make pain and also how much pain.
Wow,
Does
that's
that
so.
make sense?
Yeah,
Yeah.
absolutely, right. So you know how because I guess we experience pain at different levels or in different degrees, based on different circumstances. So
Yes.
you know how like when somebody says they're in pain because of, let's say, X, right? Something happened to them. I don't know, maybe there was a spider bite or whatever. You could kind
Yeah.
of
Yeah.
plug,
Yeah.
right?
Yeah.
The other person says like, oh, like you're being like a sissy. Like, what are you doing? Like, that's not painful. I've been bitten by a spider before. Like, who cares? Like man up or something, right? So how do we then know that in terms of like what the neuroscience shows us, how do we know then that like we actually legitimately experience pain differently, right? That it's not that one person is like lying or trying to garner attention. That no, they're legitimately experiencing pain in a different way than that other person.
Yeah, so I get emails a lot, and I hope this isn't too awkward to say on air, but like I get emails from people who say things like, I enjoy pain during sex, like I'm into BDSM or whatever. I think I got that right. Like,
Mhm.
is there something wrong with me? And the answer is absolutely not, like totally not. It's just, again, context matters. Like, so if you were just, for example, like say you enjoy getting slapped during sex or bitten or whatever, if that same thing happened while you were being mugged, you bet your ass it would feel completely different because context matters. It would
Wow.
hurt more in the context of like non-consensual getting mugged and having your wallet taken and being beat up than like in bed with a partner you like and trust. So the sensation you feel and the way your brain interprets it is always related to context and environment and the thoughts you're thinking and the emotions you're feeling. Like if you're feeling trusting and loving versus terrified, the way your brain interprets that is going to be completely different. So like you said, this like the same exact broken ankle is going to feel different for you than it is for me. And it will feel different for me if you put me in 10 different environments. So it's always subjective. It's always changing. It's so fascinating to me.
Yeah, and is it because, like, let's say if you're having sex and, like, let's say it's rough sex, is it because there's also like some degree of oxytocin and dopamine released? Is that it? Is that why it modulates the
Yeah.
pain? Okay.
Right. So remember how we said that pain lives in the middle of the bio, the psych, and the social. So that would be the bio. Yeah. Like the chemicals in your brain. It's the same like if you have a chronic pain condition, but you're out with your friends engaged in some pleasurable activity, that also is going to dampen pain volume and turn down the pain dial. Right. So the situation, the chemicals matter, the situation matters, it all matters.
Yeah. So I want to read another quote that's related to this, obviously, and then kind of get your feedback on it. So you wrote, one reason we find ourselves in this pickle is that pain has historically been framed as a quote unquote biomedical problem, due exclusively to biological issues like tissue damage and anatomical dysfunction. It has therefore been primarily treated with biomedical solutions like pills and procedures. So right now, going into the actual treatment of it, what would you say in terms of the actual medical model, and then in terms of kind of cognitive behavioral treatment, right? So do we move away from pills in terms of chronic pain, or do we kind of use it in terms of, let's say, do we take a kind of more holistic approach, right? Where we take medication and then we also take a CBT perspective and we kind of try to merge the two together? Or is it that we would go try CBT first, and then if that doesn't work, then we kind of go and, resort to medication?
Okay. You are asking a very complicated and good question.
Yeah. And I'm sure
The
I'm sure this is specific to like different ailments, right? So just,
Yeah. For sure. But in general, here's what the research shows. The research shows that a multidisciplinary approach, a biopsychosocial approach to treating pain, shockingly, is the most effective. Why? Because if you're only targeting the bio domain of pain, that's 1/3 of the pain problem. So no one is going to argue that painkillers work for pain. Like we all know that that's true. And is that a sustainable pain management technique for like many, many years? No, it's not. Like there's a lot of factors or processes that are maintaining a chronic pain cycle that are not bio. So we know that context matters. We know that situations matter and relationships matter. So if you're in an abusive relationship and you're taking painkillers, one of the things that's maintaining your chronic pain cycle, by the way, is your toxic relationships. So you can, yes, of course, you can take pain pills for your entire life. However, what research shows is that that is not the most effective way for treating pain on an ongoing basis, and that you have to target the psychological processes, the sociological factors, and the social factors if you really want to target pain. So for short-term pain, of course, yes, like Advil, Tylenol, those are useful. For a more chronic condition, yes, medications can work, but there's a lot of other, it's like very loaded also, because there's people that I work with who have been on opioids for many years. And what research actually shows, believe it or not, is that opioids over time sensitize the brain to pain. And literally what that means is your brain gets more sensitive to the sensory input from your body over time. So you are going to feel worse if you try and go off opioids because your brain is now more sensitive. So it's really awful what we're doing to people living with pain, because we're sort of like setting them up for disaster if we ever then expect them to taper off of it. And there are ethical ways to taper people off of opioids. And by the way, I'm not anti-opioid. I have read research shows it's not sustainable in the long term. So there are treatments that are like biopsychosocial. So I do cognitive behavioral therapy with my patients, and I work with their treatment team, and I work with their physical therapist, and I work with their occupational therapist, and I refer them to things like biofeedback. I love biofeedback. If you want to talk about biofeedback, let me know. But so there's this multidisciplinary approach that's actually the answer to that question.
Okay, wow, I have like a million things I want to say. But the first thing is, I'm sure for you that like the explosion in opioid use in the past decade must have been extra horrifying.
Oh yeah, and let's talk about during COVID. Like there was something like a 31% increase in overdoses and deaths, opioid related deaths during COVID. Like people were cut off from their social support networks and their treatment teams and their normal pain management strategies. And so they're relying on this medication they've been given by their physicians. But there's also illicit substance use too. So it's not just that, but it's important to talk about it.
Right. But in this case, would we mostly chalk it up to like poor education in terms of why the doctors are overprescribing?
Chalk what up to?
Well, the kind of boom in opioid use, right? So outside of the illicit use, like when they're actually getting prescriptions, right? So the central question here is, why don't doctors recommend a CBT therapist or a pain specialist? Why do they automatically say, okay, here are pills?
Well, if 96% of medical schools don't have pain education, and the pain education that does exist is a biomedical approach to pain management, how does anybody know? Like, we are not teaching doctors that cognitive behavioral therapy is important. We are not teaching doctors that pain is biopsychosocial. We're not teaching doctors that psychosocial approaches actually change the pain you feel, because pain is actually located in the brain. It's just, in my opinion, the way we're educating our healthcare providers is actually harming patients.
Right. Yeah. And I mean, it's something that we started talking about last week. I told you when I was in grad school, one of my first papers was a CBT for somatoform disorders paper. And so it's so hard for me to accept that, in America, which seems to be at the cutting edge of mostly everything technological, right, especially medicine, you would think that like this would have been already a foregone conclusion in most medical schools. So, I mean, you may not know the answer to this, and obviously that's okay, but how is this possible, right? How is it that we only have a few pain specialists in the country, but yet for the most part, doctors have no idea what's going on? Or whatever, at least have a partial understanding.
Yeah, no, I don't know. I have to be also careful how I talk about it, because of course physicians are very smart, and they are
right. That's why it's shocking. That's why it's shocking.
No, I know. Well, I mean, the other answer is, the thing we need to talk about also is stigma. So if we all have this understanding of pain as this biomedical body-based thing, people are going to experience an immense amount of stigma when you send them to a psychologist for a physical problem. And I hear that all the time. Like, my pain is real. My pain is organic. It's not in my head. Why would my doctor send me to a psychologist for a real problem? Like, people hear, you're saying I'm faking it, or you're saying this is just depression. And like, no, my pain is real. So I think that's part of the problem too, is, a lot of healthcare providers don't want patients to feel stigmatized. That's part of it. because we don't know how to talk about stigma. And I think the answer is just talking about neuroscience, because as soon as you understand the neuroscience of pain, you're like, oh, I didn't know that. Let me go target the psychosocial stuff so that I can target my pain. But if we're not talking about it that way, then we're not going to target the stigma. And then the other problem is one that you mentioned, which is, or I guess we've both been talking about it. If psychologists are not being trained in pain, who is going to deliver the psychosocial treatments required for pain to get better? Like, it isn't rocket science, by the way. Like when I first went down this rabbit hole of like pain psychology and neuroscience, like anyone who's been trained in psychology, anyone who's been trained in medicine, anyone who's been trained in cognitive behavioral therapy can use these techniques with patients. It's like, honestly, it's available and it's out there. That's actually, I wrote a workbook, the pain management workbook. And the reason I wrote it is because I have this fantasy of every therapist, like people who have not been trained in pain ever, picking up this workbook and using it with their patients who have, you know, chronic migraine or fibromyalgia or back pain or whatever, because it is accessible. It is comprehensible. Like, if you do not need a PhD in pain psychology, that's not even a thing, or health psychology to deliver it. So I have this fantasy of like, you know, distributing this workbook to every therapist in the world and being like, go use this with your patients. But psychologists in general and therapists in general are not trained in pain. That's true of social workers and MFTs and by the way, nurses and physical therapists. I mean, so
yeah, by the way, the reason why I was so interested in having you on the podcast is because literally, I think in all of the years that I've been on social media, Twitter, whatever, and like, you know, the last couple of years that we've been doing podcasts, I've never seen anybody like you, man. Like, I have never seen anybody like you. Like, I've never seen anybody who's a special, like a psychologist, you know, therapist, who's a specialist in management, right? I mean, I'm sure they exist. I'm sure they're out there somewhere. But the fact that it's such a rarity, and again, and even just going into podcasts, right? I don't hear much about it. I think there was some specialist who was on Rogan's show like maybe a couple of weeks ago, and that was it. So for the most part, people, again, just think of like pain as like, who cares? You know, you go to the doctor, you get some medication, and then you get better. So it's so fascinating that in this case, you're such a rarity, but it's also pretty cool that you're like at the forefront of treatment here.
yeah, there aren't that many psychologists. There's a couple, and I've had to really like ferret them out, you know? So Division 54, APA, Division 54 is like people who do pediatric conditions, pediatric health and pain. And Division 38 is like people who do, I don't know if there are listeners who are into psychology, but the American Psychological Association has like little pods, but there really just aren't that many out there. And it's really a shame, and it should not be that way. Like, pain is a ubiquitous human experience, and so many people are suffering, and we have this chronic pain epidemic. It's like 100 million Americans. That was pre-pandemic, and it's worse now. So, you know, and it's like 1 in 3 kids are living with chronic pain. So what are we doing? You know, it just makes me mad, and it really galvanizes me to try and, you know, raise awareness and like change the way that we're treating it and talking about it, you know?
Yeah. And I can imagine there might be some therapists who are just afraid because, you know, medication is kind of like a magical solution. So it's like, okay, if we're not going that route, and if we're essentially using like, you know, talk therapy for it, what am I going to say? How am I going to say pain, go away? What's there to do here, right? So, I mean, obviously based on ignorance, but I get why, you know, the pill would obviously be in this case kind of the go-to because it's simple, right? It's the same thing when we talk about just pure, even though it doesn't exist purely, but, you know, let's just say for discussion, pure emotional pain, right? When a person says like, oh, I'd rather just, you know, go to the psychiatrist and get a, you know, some sort of pill because it's easier than just going to a therapist, having to unpack all of my issues, right? So it's very similar with pain too, because if you think about it, most people would probably rather just go get a pill and never have to see the doctor or whatever, come up for follow-ups once a month. And that way it's like easy. Now I don't have to figure out what the actual sources are.
But then they've been in pain for 17 years and the pills haven't been working. And, you know, now you've had pain for 17 years. So yeah, you're right. I think treating pain is very intimidating for healthcare providers who aren't physicians. And I will also say it's even intimidating for physicians. Like, treating chronic pain is hard. It doesn't matter your discipline, but you're right, particularly in therapists. And again, I just want to say, like, we're very ethical people, like people in healthcare, we're very ethical, and we all feel like we need to stay in our lanes, you know? But that's why it seems so critical to me to say, if you're a therapist, you're always treating pain. Like, can you think of any sort of mental health condition that doesn't come with pain? Like, depression notoriously comes with unexplained body pain of all kinds. Anxiety chronically comes with headaches and stomach aches. Like, there's no trauma lives in the body. Like, there's just no condition I can think of that doesn't have accompanying somatic conditions. And the reason for that is because the brain is connected to the body 100% of the time. The brain is always connected to the body. So like the link for me, for psychologists and therapists, is like always talking about neuroscience, because it reminds us that we are in our lane. Like when we're talking about physical and somatic symptoms, that is exactly what we're supposed to be treating, because it's part of the psychological makeup. It's part of the condition you're treating. Anxiety is somatic. Depression is somatic. Trauma is somatic. You know, there's this great book, The Body Keeps the Score. It's like about how trauma lives in the body. So I talk about that one a lot. But for therapists, like, I think we just need to like own and embody that we are always treating pain, and just pick up a stupid workbook. Like the pain management workbook is really accessible. It has all the pain science, but there's other ones out there too. Like I didn't write the first CBT for pain workbook. There's others. So that's a resource that it's accessible to us, but I have colleagues all the time that are like, don't send me chronic pain patients because I've not been trained in pain. And I'm like, right, because there isn't any training. You're going to have to do it yourself.
Right. Yeah, and so before moving on to treatment, I also want to say how wild it is that there's this inverse correlation where you have on the one hand, right, you're sort of the medication and the opioids. They make you kind of more sensitive to pain, but then on the other hand, there's also a desensitization where you become less susceptible to them.
Yeah.
It's so wild. It's so wild, man. So it's like, I don't get how it even does. So maybe you might not know this, but do doctors—
Your mic is doing a really weird thing, by the way.
Let me turn it on and off. Hold on. This is where editing goes. It comes in there. Okay, how is it now?
It's better. It was making a weird monster noise.
No, it's all good. Yeah, so that sometimes happens. Thank you for pointing it out. I was actually on the podcast like a couple of months ago and nobody said anything, and then they recorded it like this. I was like, no. Okay, so it's good, right?
Yeah, it's better now.
Okay, cool. Thank you. Yeah, so the weird correlation or whatever, the awful correlation and strange correlation. So the awful correlation between opioid use. Yeah. So in terms of like doctors, right, what do they think about it in terms of the long term, right? Do they just think, oh, hopefully this person will get better and then we could kind of wean them off of it? Or what do they think of in terms of chronic pain and opioid use? Like, how is it sustainable?
The language I hear a lot from doctors is, we just need to break the cycle. Mm-hmm. I hear that a lot. We need to give your body a break and break the cycle. But that's not what opioids do. Opioids don't break a pain cycle. That isn't actually how that works at all. But patient after patient will come into my office and say, well, my doctor says we need to break the cycle. Yeah. So that's not what's happening with, yes, we do need to break the cycle, and there's other ways of doing that, but opioids don't do it, unfortunately. They do provide a lot of relief. No one will deny that opioids, by the way, thank God for opioids for acute pain, like post-surgical pain. Thank God. No one will deny that they work, but for long-term, like multi-month, multi-year, no. But that's the language we're using. And we know it's not working, and it's actually increasing and not decreasing suffering.
Right. And I guess that's where it becomes scary for these physicians, where they start thinking like, oh, okay, well, we don't know what to do with this long-term. So, I guess if they're still in, if there's chronic pain and if they're still in pain, I guess there's nothing that we could do. We could just throw our hands up and just keep using the medication.
Yeah, exactly right.
Yeah. Okay. So treatment, right? So what happens when you go see a cognitive therapist and somebody who's a specialist in pain management?
So you mean for someone living with pain, like what kind of stuff do I do, you mean?
Yeah. So with somebody living with chronic pain, let's say they've been through maybe, I was going to say plethora, but let's say even a few doctors, right? They've been to a few doctors, I just sent them to a therapist. So they said, hey, we just don't know. Maybe they've tried opioids before and they wanted to get off of them. So in terms of like the actual CBT approach and looking at it from a cognitive behavioral and, I guess a biopsychosocial perspective, right? How would a therapist treat that person?
So the first thing I do in my practice is I ask people, hey, so you've been in pain for 4 years. Has anyone ever explained to you how pain works? And they always say, no one has ever explained to me how pain works. And once they're righteously indignant about that, I launch into my explanation. I ask them if they want to know. And as soon as they're curious about how pain works, like I need to have buy-in. Like my therapy, my treatment will not work as long as you believe that your pain is just located in your back and you require like 8 more surgeries to fix your back. Like nothing that I do will help you if you don't understand pain. So I ask if you want to understand pain. So cognitive behavioral therapy for pain is multi-component. So one, like any good therapy, you have to establish a rapport with your patient, with your client. Without rapport, you got nothing. So that's part one. Part two is always pain education. So pain education is what we're doing today. Like how does pain work in the brain? what's, what are the things that change pain? What changes pain volume up and down? We can talk about that. Then there's the behavioral strategies. So the B in CBT is just behaviors. So again, there's a lot of things or behaviors we can engage in that will amplify pain, like not moving and not seeing people and not exercising and just staying sedentary. And there's a lot of behaviors that can change the pain you feel. So we always talk about mapping out, like, what are the things, what's the cycle I'm stuck in that's not helping my pain and making it worse? And what are changes I can make in my behavior that might make pain better? And there's like a million behavioral strategies. So the B in CBT is like pacing for pain, and pacing for pain is like returning to life and activities that you love, like tiny little bits at a time. So it's like pacing for a marathon. You would not go run 26 miles tomorrow if you haven't been training. You're just like gonna lie face flat on the pavement. And it's the same with pacing for chronic pain. You do not go outside and engage in all of life's activities just because someone told you to. You have to gradually desensitize your brain and get your body prepared or ready for that. So that's one of the behavioral strategies. We also use like mindfulness-based stress reduction, which helps turn off your fight or flight pain alarm. We use distraction strategies to engage your prefrontal cortex. So there's like a lot of strategies that we use for pain management that hit the B, the behavior. And then we also hit the C in CBT, which is cognitive strategies. So how are the things I'm thinking impacting my body? So am I sitting around thinking I'm broken, I'll never get better, nothing's ever gonna help me? Like, what are the thoughts I'm thinking and how is that impacting my body and my health? Or am I thinking, I've never tried the CBT thing before. I hear that it's helpful for some people, at least I'll try. Like, what are the things you're thinking, and are they stopping you from trying things to get better, or are they galvanizing you to make change and heal? So thoughts affecting. And then the fifth component is like caregiver training or parent training. So there are things that your support network can do to help you get better, or parents can do to help children get better. And there's things that we can do that actually impair wellness. So it's multi-component. And people always ask me, well, how long is this going to take? And the answer is, it depends. Like, every single person who walks in my door is different. There's like no one answer to that. And the shortest patient, it was like 6 weeks. Wow. And she had like this chronic migraine condition, and she couldn't even talk because her pain was so bad. And it took 6 weeks of like training her and training her parents, and the pain broke, and she like went back to soccer practice and like, but some of my patients I've been seeing for a really long time, and they have complex trauma, and there's like a lot of stuff going on, and it's, and also they like want the support. So there's really there's not one answer, Yeah.
And then, so how is complex trauma interwoven? How does it kind of fit with the idea that, there's kind of an emotional and obviously a biological component to pain?
So there are these studies called the ACEs studies from 1998. This guy, Felitti, I believe he's a he, and I'll be very embarrassed if she's a she. It's the adverse childhood experiences studies, and they showed unequivocally that early childhood trauma and toxic stress was predictive of chronic pain and chronic illness later in life. And there have been like hundreds of studies since then that have confirmed that that's true. And the biology of that is just this. If pain is the body's warning system and it exists to protect you, if you've had an early trauma early in life, your brain knows that the world is not a safe place. And what early trauma does is it makes your brain more sensitive. That's literally, when we talk about PTSD, hypervigilance is a symptom of trauma. And hypervigilance literally means your brain is vigilant. It's on alert all the time. And it wants to warn you of potential threat of danger. So your brain is constantly scanning the environment around you, but also your internal environment, your body, to look for any threat of danger. So when your brain is on high alert and it's sensitive, what it means is your brain is going to amplify information from the body. So small bits of sensory input to a sensitive brain are amplified. So it predisposes you for a chronic pain condition, because your brain is now really sensitive. It's hypersensitive, and it's trying to protect you and save your life. But the pain system is fallible, like every system in the human body, and the pain system can fail.
Right. So is it then that the anxiety or the fear amplifies whatever symptoms or whatever signals your body is sending to your brain?
Exactly. That's exactly right. Stress and anxiety are always going to amplify danger messages. So the pain you feel is going to be worse when you're stressed and anxious or traumatized. Always.
Wow.
That's how that goes.
Yeah, wow, that's so amazing. And then, so when we think about thoughts, is it the same thing too? So where the connection is between thoughts and emotions and pain, where it's like, let's say, if I'm down on myself and if I feel like a failure, nobody wants to be friends with me. Let's say, maybe my life is going nowhere, right? Then obviously I'd automatically likely be depressed. And then the idea is with the depression, that is like in terms of that pain modifier, it sort of turns the dial up, right? So it's like the more depressed you are, the more in pain you are. Whereas opposed if we were to reframe some of those thoughts and you felt better about yourself, you had a better outlook about life, then obviously a little bit, you're a little bit more cheery than you would have been otherwise, and then the pain dial goes down.
Where you got it. That's right.
Okay. So interesting. Wow. So it's like, you kind of, I guess I'm assuming when you're in session with patients, right, and you're talking about this, you probably kind of get into the fact that, yeah, a lot of your thoughts literally are toxic. Like, it's not just that it's toxic in the sense of it's ruining your life. It's toxic in the sense of it's ruining your body.
Well, so I always think about how to talk about this, right? Because if you think about what a thought is,
Mm-hmm.
it is physiological. It's a neurological change in your brain. It's chemicals, and same with emotions. It's like, it's electricity and neurotransmitters, chemical changes in your brain and in your body. It's hormonal changes and changes in muscle tension and changes in all of that's what thoughts and emotions are. They're physiological. So yes, of course, thoughts and emotions by definition have to affect your body. Again, the brain and body are connected 100% of the time. So the things you think affect the things you feel. There's just no way around it. So the reason I mentioned biofeedback earlier. Biofeedback is a treatment for chronic pain that connects the brain to the body. And the way it does that is, so when I first started treating pain, people said, you need to send your patients to biofeedback. And I said, I don't send my patients to anything I don't understand. So I went to a biofeedback provider and he sat me in a chair and he said, I'm going to teach you to warm your hands to 90 degrees. And I said, I am a scientist and I don't believe in voodoo. But he sat me in this chair and he hooked me up to these machines, and the machines were reading my hand temperature and my muscle tension and my heart rate and all these other things that are normally unconscious. But I could see on the screen my temperature, my heart rate, my muscle tension, everything. So he used all of these techniques with me. He had me think relaxing thoughts. He had me, he did a guided body scan with me, which is from mindfulness-based stress reduction. He used a bunch of imagery. So he told me that he was going to help me warm my hands to 90 degrees, right? So he had me imagining my hands over a campfire and like warm fluid running down my arms and into my hands, which totally sounds crazy, but you're changing your thoughts and you're thinking about your hands heating up and holding them over a campfire, and you're thinking about warm fluids like running down your arms into your fingertips. And I've been doing it for so long now that even just talking about it makes it happen. But there's no denying it with biofeedback, because you're getting feedback about your biological systems. And as you're thinking these thoughts and imagining these images, your hand temperature is slowly going up. It's just wild. So the things you think are connected to the things you feel 100% of the time. And biofeedback is a great way of proving that to people. And he also, to prove it to me, had me think about really stressful things and really stressful thoughts. And my hand temperature plummeted and my muscle tension went up and my pain got worse. So there's just sort of no separating the two. But for some reason in Western medicine, we separate the thoughts and emotions are over here in psychology and the body's over here in medicine. But like, that's not how that goes.
Yeah, wow. And what's so incredible about that is if you think about, for the most part, why people avoid therapy is because they don't want to talk about these traumatic incidences, right? They want to kind of stay away from there, from that kind of area. So would you say then, for somebody who is a little bit skeptical of it, or at least hesitant of it, that for them biofeedback would be a great kind of avenue, I guess a first start?
Definitely. I love biofeedback. It's awesome.
That's so cool. Wow. Okay. And then, so also before we go, I really wanted to touch on the anecdotes. So you write about the tale of two nails. Can you tell us about them?
Yeah. So the tale of two nails came to be because I was trying to find a way to highlight this concept that things that hurt aren't necessarily harmful, that there's this distinction between hurt and harm. So hurt is pain, and that's subjective and absolutely real, and everyone experiences it to different degrees depending on context and all the things we talked about. And then there's harm, which is like undeniable damage to the body, right? Like a broken bone or like a bloody wound or a disease process, right? There's like, so The Tale of Two Nails are two stories from the clinical literature. They're both construction workers. Do you want me to tell the stories?
Yeah, please.
Okay. So
You don't have to, obviously, if you feel like it's too long. But yeah, they're really interesting.
it is really interesting, and I think it actually is too long. I'm sorry. Is that okay?
Yeah, it's okay. So but like kind of the gist of it essentially is that like there was this construction worker, right, and who kind of shot a nail gun through his boot, and then he thought he was in severe pain, and then after a while they kind of figured out that, oh wow, actually, the nail never actually hit your toe or you didn't hit your foot. So the question there is, right, how is that possible? How is it possible that a person can actually perceive to be in pain, right, in some sense, but then actually not be in pain, or at least at the very least, the kind of the body interprets pain where there is none. But just in general, I feel like it's really amazing that stuff like that happens. And I mean, is that something that you kind of see with sometimes? I mean, obviously you're not going to see a person like put a nail through, have a nail put through the boot or whatnot. But do you ever kind of see that with your patients too? Sometimes where they kind of let's say they've experienced pain in the way where, let's say they even went to a doctor and there was nothing that could be found, right? That there was no, like when we're talking about somatic pain, right? How often do you see that?
I feel like a lot of the people who end up coming to me are coming to me because the doctors haven't given them a sufficient answer, or the doctors have said like, we don't know what's causing this, or the medications aren't working. So I see that a lot where there's like not a great answer for like why the pain is happening. And surely there's not a great solution. Like no one comes to my office if they've found a solution to their pain, So I see it a lot.
Yeah, so incredible. All right. So if there was like, let's say one big takeaway that you would have, let's say, your audience or the people reading your book have, what would that be?
The one big takeaway I would say is, in order to effectively treat pain, we have to target the brain in addition to the body. And we have to target the brain in a way where we're not just throwing pills and procedures at people with pain, but we're also delivering psychosocial treatments like cognitive behavioral therapy or biofeedback, or PT and OT, but all of these things together, that's actually the treatment for pain. It's not going to work to exclusively just throw pills and procedures at it for a chronic pain condition. It's just not going to work.
Yeah. And I really love the fact that your book is highly accessible. I mean, that's kind of the point, right? You want it to be, not only for clinicians, but for people, just, regular people kind of day to day, using it for their day-to-day lives. And so I love that, in particular, if you're somebody who's kind of hesitant about therapy, or somebody who kind of wonders, I don't really like, what would it be like? Or I don't really want to go to a person and open up about my struggles. I just don't feel comfortable with it. It's kind of a great resource for them.
Yeah, exactly. And that's the thing about cognitive behavioral therapy for pain is like, you actually don't necessarily have to talk about all the things. You just need to know that those things are amplifying your pain and be willing to do something about it. Again, like toxic relationships or any form of abuse, or, not having good access to care. Like there's a million things that affect pain, like being depressed, being anxious. So like in order to target pain, we have to target all of those things. So it's okay to not want to talk about it, but we have to at least treat it in some way. Like we have to target it in some way,
I love that. Okay. And then, so if we were to find you and follow you online, where would that be?
Yeah. So I have a really dorky website. It's just my last name. It's zoffness.com. I joined social media during the pandemic because I wanted to connect with people and I was so isolated. It was miserable. So on Twitter, I'm at Dr Zoffness. And I tweet a lot about like pain stuff and like nerdy science stuff because I think it's fascinating. And on Instagram, I'm at the real Doc Zoff because I got nervous and I couldn't think of a better handle.
Well, I love your Twitter. It's one of my favorite Twitter feeds to follow.
Oh, thank you. Nice compliment.
Thank you so much for coming on.
Thanks for inviting me.